All right, so picking back up at thyroid, just like I said before, in order to understand what the medications that we are going to discuss, we need to understand what the disorder consists of itself, right? So, what is our thyroid responsible for? It is a hormone, so metabolism is going to have is going to be the name of our game, okay? That is going to be explain if you can remember that your thyroid impacts your metabolism, then all of the signs and symptoms that come from that are going to be related to your metabolism, okay? So, what would be our goal in caring for somebody with a thyroid disorder? Stable levels, right? That is going to be our goal. So if they have hypothyroid, they have not enough thyroid. If they have hyper, they got too much. Okay, so the medications that we're going to treat are going to be opposite of that. That's pretty easy, right? So what would we be worried about if that's how our treatments work? What would we be worried about? That's right. So overcompensating or under treatment, then I'm still measuring their levels in order to be able to determine if they're normal. Is that easy enough for everybody? I feel like this is a fairly easy um, thing to wrap your head around. Okay, so for hypothyroidism, like I said, this is related to your metabolism. So you can see here that everything in hypothyroid, your metabolism is going to be slow. Okay, so everything is going to be slower. Um, the One of the things to consider is if this is in childhood, that it can inhibit their growth. Um, and another thing just to be cognizant of, your thyroid stimulating hormone, what do you think that does? Man, y'all are good. So that is what it does. It stimulates your thyroid, and then your thyroid is what releases those hormones, right? The T3, T4. So if I have low thyroid, if I don't have enough thyroid hormones, what is my TSH going to be doing? It's going to be up because my body is saying, hey, I need more thyroid hormone. And so it's telling the thyroid stimulating hormone is saying, make more, right? But my body can't do that. So the thyroid stimulating hormone is going to be high. My thyroid hormones are going to be low. T3, T4 will be low. Okay? Yes. There's lots of different things. So maybe I'll remember it. I'm sorry. I don't know. I don't remember what I said. It's telling my body to make more. It's telling the thyroid to make more because I don't have enough. So it's signaling the thyroid stimulating hormone is trying to tell the thyroid to make more, but it can't. So the thyroid stimulating hormone is going to be high and the T3, T4 will be low. Okay. And this, correct. hmm Most of the time, this is autoimmune. So, this is, if you hear like Hashimoto's, that's what's associated with this. A severe complication from hypothyroidism would be myxedema coma. Okay. Um, so, now we will go to hyperthyroidism. So, this is going to look opposite. All of the symptoms that are going to be associated with this are going to be high metabolism, okay, because they have high thyroid hormones. So their T3 and T4 are going to be high. And because of that, because their body says, hey, I got lots and lots of thyroid hormones, what is their TSH going to be? It's going to be low because it says, I don't need to make more, right? I need to not make any more of that because your T3, T4 is high. Okay. So Graves' disease is generally what is referred to or associated with hyperthyroidism. And the bad complication from this is thyroid storm, which is really just an exacerbation of these symptoms, okay? Or extreme, I guess, of those symptoms. So the medications that we are going to be talking about are going to be in treatment for hypo and hyperthyroid, okay? So, the first is thyroid replacement. And I will say, just in my experience, this is more commonly what I have given medication for. Okay. More commonly, I have treated people with medication for hypothyroidism. And you do that by giving them a thyroid replacement. So, this acts like our thyroid hormone would act in our body. So to replace the thyroid, you're going to give medications that are going to act similarly to T3 and T4. Um, and when you, the types of medications they are, I have listed here. So to simulate T4, levothyroxine falls in that category. That's the most common medication that I have given. Um, T3 only is liothyronine. Cytomel is a common brand name for that. For the levothyroxine, Synthroid is a common brand name for that. And then you have combo medications of T3, T4. And then you also have the desiccated thyroid. So the desiccated thyroid, also referred to as armor thyroid. I think I've given that to one patient in all of my years of being a nurse, not to say that they aren't prescribed, but that is actually derived from pig thyroid, and it's not used a whole lot because it is not as standardized, I guess, not as easily replicable, and the amounts of it aren't as consistent. So that's not used a whole lot. But in our bodies, T4 converts to T3 in order to elicit the response of our thyroid hormones. Okay. So when you're giving T3, if that's the medication that you're giving, the liothyronine, those are going to act more quickly. That's going to automatically do the function, okay? Whereas what's more abundant in our bodies all the time is T4. Usually those levels are higher than T3. When you replace with levothyroxine, the T4 mimicker, then that is going to function more similarly to how it does in our body, where that's going to take a little longer for that to convert to T3 for it to do its job. Okay. So in knowing that, um, the way that you decide, or like what is a better indicator, would be if somebody needs it more quickly, right? Like if they need that to work faster, they don't have time for it to kick in. Okay. So if they were in more extreme cases, so myxedema coma, if somebody is to that extreme, they're either going to get IV levothyroxine or they'll get the T3 mimicker, the liothyronine. Okay. Is that making sense? I'm trying to talk my way through this. Yes, ma'am. So, yes, that is true. I'm glad that you brought that up. So, this is for an emergency, right? So, I'm giving that, but yes, in order for it to do its function, you are supplementing with T4. But that is to distinguish when you would administer these. And it's important to know how quickly that's going to act, because to be able to anticipate those symptoms, especially if you're giving both, of I'm looking out for what? What would I be looking out for if I'm giving a combo of L3, I mean T3 and T4? Too much. I'm looking for that high metabolism symptoms, right? Yes. So I'm looking out for those things. So my adverse effects that I'm looking at are going to be hyperthyroid. So you're looking at high heart rate, weight loss. I'd say heart rate is probably one of the biggest things that you're paying attention to. And one important thing to keep in mind is these aren't going to take place immediately. So as you're replacing their hormones, this takes time to do its job, to kick in, to function like it is supposed to. So you're going to have a better indication of that replacement. First of all, how would I know if it's working? Levels. What else? I'm looking at my patient, right? I would expect that that lethargy, the low metabolism, that has changed, right? That there is some change in their presentation. But also, once those levels have stabilized, usually in about 6 to 8 weeks, you can check their levels and those should have replenished. Okay, that would be a better indicator of that. It is very important to give this can interact with meals. So we want to make sure that we give levothyroxine 30 minutes before a meal and other medications. Okay. Very important to give it at the same time of day because this is mimicking a normal hormone that we have in our body, right? Functioning like our metabolism. So making sure that that stays steady is very important. Um, when I'm teaching my patient, it would be very important for me to distinguish what those signs and symptoms are that they're looking out for, right? When I would be cautious in giving this is in somebody who has thyrotoxicosis, who's had a recent MI. Renal impairment is going to um, affect their processing of it. So just using caution with that. And then in older adults, yes. I'm sorry. Oh, so those specific medications would be within 4 hours because those are antacids. Those are going to impact the absorption of it. Okay. So those specifically are 4 hours. Other medications would be 30 minutes. Thank you for asking that. So food also reduces the absorption. Again, why I'm giving that 30 minutes before a meal so it has time to take effect. Um, just as a general statement, seizure medications, antidepressants can cause decreased levels. Anticoagulants are going to increase. This increases the impact of anticoagulants. And then when we give epinephrine to somebody who is also getting this, it is going to increase the cardiac effects. Okay, so if they were, we already know that. This is going to increase their metabolism. So if I give epinephrine, those impacts are going to be increased. Okay. Like I said, for levothyroxine, myxedema coma would be when you give that IV, and other emergency type situations. Otherwise, most of the time, this is given in a pill. And I will say these are dosed, I think, in like 0.25 increments. So it is very easy for them to get. Like the exact amount that they need for their replacement, so that they're not teetering on either side of that. Um, I don't think I have anything new. Like I said before, this is really just, I have it broken down to more explanation on the different slides. I think I said all of these things. Levothyroxine, yes. Um, One thing to keep in mind is if I am chronically overtreating somebody, if their levels are chronically high, then that is going to contribute to them being at risk for atrial fibrillation, and also osteoporosis. Okay. So, what would be very important for me to teach my patient when I'm sending them home on this medicine?
Keep track of when you take this.
Don't overtake it. What else? Recognize those signs and symptoms of if it's too high, because you need to call your doctor, right? What else? Yeah, okay. That's that's good teaching. Take vitamin D. What else? Take it at the same time. Take it as prescribed, right? Take it as the same time with every day. Take it at the same time every day. Don't take it with other medications, and then make sure that you teach them they have to go get these levels checked. There are plenty of people who you send them with a bottle of pills. Oh yeah, okay. They're never seeing you again, right? Very, very important that you explain, first of all, what that disorder is, what that's going to look like, what are the consequences of you not taking this medication, which would be a coma. Very important that we take this medication. If you're not taking it correctly, following back up with your doctor and having your levels checked, you also die, right? So, very important that you are going regularly. And usually, once people, it really just depends on the person, but somewhere between every 2 to 3 months, I would say, people go and get their levels rechecked. Okay. Yes. Is it different?
A little.
Oh, sorry. Sure. Um, it is, um, hold on. I'm trying to make sure. Okay. 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 Gotcha. So if somebody has adrenal insufficiency, this is going to, if you give them thyroid replacement, it is going to increase the metabolism of the treatment for that. Okay. So if they are on glucocorticoids, then I am going to make sure that I give the steroid first before I give the levothyroxine. Okay. Um, After patients have had an MI, I want to use caution in administering this. If they have heart problems, because like we said, this is going to increase their heart rate, right? Increase their cardiac workload. Make sure you use caution in older adults and those with diabetes. Very, very big point here. This is not used to treat obesity. So one of the symptoms of hypothyroidism is weight gain. I have a friend who was very, very heavy. Like she she should be the poster child for hypothyroidism. She was like a chubby kid, but as she got older, I mean, like her face was just ballooned, like very heavy. Well, she found out that she had hypothyroid. She got on levothyroxine, and I kid you not, like a month, she dropped 100 pounds. It was insane. I've prayed for thyroid issues my whole life. I would love to just drop 100 pounds in a month, but that is not the treatment for this. Okay, so obesity, this levothyroxine is not. That's a joke. Also, I pray I do not have thyroid issues. It is not used to treat obesity, but because that is a side effect, if a person is overweight, I mean, yeah, if they're overweight, if they have hypothyroid, you treat it, they will lose weight. That is a symptom. So tell people not to take their friends' levothyroxine. Um, Make sure that we're monitoring vital signs. We know it can increase heart rate. their thyroid stimulating hormone and their T3, T4 levels, right? If they have cardiac symptoms, make sure that they report that. We check their apical pulse prior to administering it, make sure that we have, it's within a safe range that we can administer it. And then making sure that they do not discontinue the use. We've already discussed that. And then also not change brands, which I don't know how they would do that without talking to their doctor, but they wouldn't do that. Um, and then continue to check those levels. Okay, so now we're flipping the script and we're going to hyperthyroid. Okay, so this is anti-thyroid. So this is going to not make them not have thyroid hormones, okay? Or try to reduce those levels. So these are also known as thiamides, and it is used to treat hyperthyroidism either with the medication or after they've had with radiation, okay? And we'll talk about radiation on a couple of slides, I think. So it is going to function by blocking iodine from being integrated into tyrosine, which then blocks the conversion of T4 to T3. Okay, so it is blocking the way that those hormones T4 turning to T3 so that our body can use it. Okay, so that is how it's decreasing that level. Is this targeting your thyroid hormone that you have in your body right now, the level that you have? It's not. Okay, so it's preventing new. It's not killing what's there, if that makes sense. It's not depleting that current level. So I'm not going to see side effects, or I'm not going to see the impact of this immediately. I'm going to see the impact of this more long term. Does that make sense? Because it's not actively targeting that. It's just preventing new from happening. So another medication in this classification is methimazole. I also just forgot to say that the prototype drug for antithyroid is propylthyracil, or it's more easily referred to as PTU. Adverse effects of this, if I am targeting that hormone, blocking that hormone, what are my side effects going to be? Hypo, right? That's the potential complication. Aplastic anemia is also a potential complication from this. So if I am worried about aplastic anemia, if that is something that can happen, what am I looking for? What would that look like? Could be. They might have petechiae. What else? Okay. Yeah, if their blood levels are decreased, they might be at risk for falls. Their blood count, right? If I look at their blood count, it's going to be lower. That is how their hemoglobin, their hematocrit, that's going to be lower. Another big side effect of these are agranulocytosis. Do y'all remember what that is? $100. Just kidding. Y'all might take me up on it. Your white blood cells go down, so I'm going to have low neutrophils. So what does that mean? My immune system is not going to be great, right? So if this person presents like they're sick, like they have a cold, like they got a sore throat, and they have low neutrophils, then that could be an indication of a potential adverse effect of this. Okay, so those are things that you're monitoring for. Hepatotoxicity, what is that going to look like? What'd you say? Okay, their liver function test might be elevated. Jaundice, very good. What else? What goes along with the liver? I'm itching, right? We have that profuse itching from the increased liver enzymes. Huh? Could have dark urine, yes. So those sorts of things, when I'm going through that with y'all because like I said, when y'all are doing those drug cards, if what you're writing on that, because you think you're turning this in for my sake, is agranulocytosis is what you're looking for, and you don't know what agranulocytosis is, you are going to suck at taking care of your patient, right? Because how am I going to know if they're having a side effect if I don't even know what that word means? That's gonna be very hard for me to do. Okay, and I'm saying that for now, and also for when you are actually taking care of somebody. If you go look up a medication that you have never given before and you see a word that you have no idea what it means, what are you going to do? Please, yes. Google, Yahoo, Bing, ask a friend. Don't care. Figure out what that is, okay? Because otherwise, how are you going to know? You would have absolutely no idea if that's what you're looking for, okay? Other side effects, rashes are fairly common. Nausea, vomiting, joint pain, headache, and dizziness. So you want to give this at regular intervals. Usually it's given 3 times a day or every 8 hours. And then make sure before you administer this, I know what their levels were because then I'm going to be rechecking those and I would anticipate that those go down, right? So I'm looking at TSH, T3, T4 to see what those levels are and if my treatment is effective, if I'm giving too much, if I'm not giving enough. Also monitoring vital signs, their weight, and making sure that they don't stop this abruptly. PTU can be used during pregnancy, and just know that if this is stopped abruptly, that it can cause thyroid crisis. All right, so methimazole, this is all going to be very similar to what I just said. All of those things are just spelled out a little differently for you. Well, like I said, if we over medicate with this, that's going to look like hypothyroidism. If that I notice that, then I am going to contact the doctor, and they are either going to tell me to increase my dose, right? Or just kidding, decrease my dose. Um, or if it's severe enough, I might then have to give thyroid replacement, okay? Because now I've done too much and now I got to get it back to where it's supposed to be. Does that make sense? Okay. So agranulocytosis, we talked about that. Usually that's going to happen within the first couple of months of giving that. If I notice it, then I need to stop the treatment to make sure that that resolves. For the methimazole, I can't give that in pregnancy, or I want to use caution. And with people who have bone marrow depression, immunosuppression, or liver failure, because we said that those are potential complications, right? So if they're already at risk, that's just going to exacerbate the potential for that to harm them. While I'm giving this, monitoring their weight, their vitals, looking for those signs of hyperthyroidism, which means I'm not doing enough, I'm not giving enough. They might need an increased dose, or hypo, which means we've given too much. If they are experiencing tremors and tachycardia, then we might give beta blockers to counteract those symptoms, okay? I said before that a beta blocker is going to slow my heart rate down, okay? So that can be used to treat those symptoms. Just as a little aside, I know y'all are going over cardiac right now, and we will be talking about it very soon. LOL is your beta blockers. Okay, so most of the time, I can't think of an instance where it is, but I'm sure there is. But most of the time, LOL means beta blocker. Okay, those usually fall into that category. And then I'm monitoring my CBC and my white count, looking for that anemia and agranulocytosis. So to teach my patient, because I know how this medication works and because I know what potential complications are, I'm going to tell them to report if they have fever, chills, headache, any signs of acute illness, specifically associated with taking this medication. Now, let's say my patient's been taking this medication for 10 years and they have a sore throat. Am I going to stop their medication? Right. I will be more cautious. I will look at their lab values. I will see, but that risk that you're monitoring is going to be during that initial treatment. Okay. It still can have that effect. So, yes, I'm using that more caution. I'm paying attention to it. But a lot of these things are going to be similar. Like, as long as nothing has changed in their medication treatment, if people have symptoms that just so happen to, let's say, that I'm on a medication that makes me have a high heart rate, and I just ran 3 blocks, and you check my heart rate, and you're like, oh God, we got to hold this medication. Like, no, that's probably not what caused the high heart rate, right? So assessment plays a really big role in you making your decisions, and just honestly a conversation with your patient. Make sure it's with meals at the same time, to decrease those gastric effects, and also make sure that their levels stay maintained. Don't stop it abruptly, and then don't take over-the-counter meds or herbs without asking a doctor. And I would say, if you read Tylenol, it tells you that, right? Like, that is just a general statement. Shellfish contains iodine. And so if they are taking something with iodine or consuming shellfish, that is also could impact their levels. So tell them to use caution, and you be aware of also. So another anti-thyroid, yes, ma'am. No, the anti-thyroid. Well, I guess honestly, yes, all of them. Yes. Not eat it. Use caution. You wouldn't want to have it 3 times a day for every meal, right? Or if you come in, you check they're presenting with symptoms, and you do a history on them, and they say, I've had a crawfish boil 5 days this week, like, that could give you an indication of what could be playing a role. Just use caution, okay? Um, Antithyroid, other drug, radioactive iodine. So this is going to treat hyperthyroidism, and this basically, like, targets the thyroid gland and destroys it. That's its goal, okay? Um, this will permanently damage the thyroid, so they are going to need replacement forever and their levels to be maintained, okay? Um, they might also, this isn't necessarily to do with this, it could be used in conjunction with it, but they might also have part of their thyroid removed in order to compensate for that. Okay. Um, if it is damaged, or if their thyroid is removed, what are they going to need, or what might they need? They might need thyroid replacement, right? Because now their thyroid is damaged. So just maintaining, the biggest thing with this is going to be making sure that they're following up on their levels, right? That they're consistently having their levels checked. It can cause bone marrow depression and radiation sickness. It is given PO by capsule or solution. Very, 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 very important before I give this medication that my patient has a negative pregnancy test, and that they also are doing what? If they can't take it while they're pregnant, they have to be on some sort of birth control. Okay, so they're going to have more frequent tests to make sure that they aren't pregnant, because that can be harmful to their baby. They'll do thyroid labs before they begin this and then monitor them throughout. It is contraindicated for pregnancy and lactation because it crosses the placenta and breast milk. And then it also can cause infertility. So prior to administering this, it would be very important to make sure that they're aware of that, right? And usually surgery would probably be preferred over this. Can also cause thyroiditis, pulmonary edema, and or is used contraindicated with pulmonary edema and tuberculosis. Toxicity is going to look like they're going to have their blood levels are going to be impacted. Okay. All right. So we'll ask a question. When talking with a 30-year-old woman who will receive radioactive iodine to treat Graves' disease, you should include which of the following? And we're selecting all that apply. Who says A? Report weight gain and edema. Okay. Use effective contraception. Everybody raise your hand. Thank you. Allow 2 to 3 months for full effects. And expect periodic blood sampling. Yes. Okay. Obtain regular eye exams. No. Sure, why not? But no. Okay, so very good. And then A, B, C, D. All right, so now what time is it? Do y'all need a break? Yeah? Love it. Okay. To the hypothalamus. So what does our hypothalamus do? It deals with hormones, right? Which is why we're talking about it with endocrine. So the two that we are going to focus on are ADH and growth hormone. Okay. So with ADH, what's ADH? Antidiuretic. So what does an antidiuretic hormone do? Makes you not diuresed, right? So I am keeping fluid. So if I don't have that, what am I doing? I'm losing fluid and I'm peeing a lot. That is correct. A growth hormone, what do you reckon that does? You grow, right? So if I don't have it, what am I not doing? And if I got too much of it, what am I doing? I'm growing too much, okay? That I feel like that is easy enough. So what I am looking for is those things. Are you peeing? Are you not? Are you growing? Are you not? Okay. And I'm measuring those levels to ensure that those are adequate. Okay. So growth hormone. This is going to mimic your growth hormone. The prototype is somatropin. And it is going to facilitate growth and protein synthesis. Um, it functions by stimulating the release of insulin-like growth factor from the liver and other tissues. The adverse effects of this are going to be hyperglycemia, and pancreatitis. It can be given IM or sub-Q. Sub-Q is what is preferred, and it is generally given daily or could be given just several times a week. If I'm giving injections, what's very important for me to do? Rotate my sites. That is important, okay? If I'm sending somebody home giving injections, what is important for me to teach them? Rotate your sites, right? That is, and clean it. That's very good. Huh? Very good. So I'm assessing my site. Rhonda also said I'm going to tell them to clean it first. What else would be important if I'm sending somebody home with needles? Don't reuse it. Don't give it to your friend. Proper disposal. So how are they going to dispose of it? I am putting it in some way where the poor little innocent trash man is not getting poked with my needles, right? Very easy thing to teach somebody. A Coke bottle, a laundry detergent bottle, a orange juice bottle, whatever, something that's hard and plastic that's protecting them, okay? When I am giving this to children, it is going to be very important for me to monitor their growth, okay? Because I'm giving them growth hormone. Um, it can be given in the abdomen and thighs. Before you give it, you would want to know height, weight, thyroid function, growth hormones, and then I'm going to monitor thereafter, okay? They will have annual x-rays to check for those things. This is supposed to be given before children's epiphyseal plates close. So they are monitoring for that. I wouldn't want to give this in severe obesity. If somebody has respiratory impairment, use cautiously in people who have diabetes, hypothyroid, renal failure, or Prader-Willi syndrome. So that syndrome is a chromosome disorder that causes stunted growth. And so they will administer this to help them grow because their growth is stunted, but the problem isn't growth hormone. So I want to not give them too much. Does that make sense? The problem is they have a chromosome abnormality. So I can't fix that by giving them growth hormone. So they're going to give them the growth hormone to supplement, but it will be used very cautiously. Okay, you wouldn't give this in the same degree that you would somebody who has impaired growth hormone. Is everybody following that? Okay. All right, antidiuretic hormone. The prototype for this is desmopressin, also DDAVP, or vasopressin. Brand name of that is pitressin. This is used to treat diabetes insipidus. Okay, so when somebody has diabetes insipidus, they don't have antidiuretic hormone, so they are, what are they doing, Roland? They're peeing a lot, okay? So they are going to be dry inside, okay? Think of that as diabetes insipidus. They are dry inside. They have peed everything out, okay? So I give them, and it is, they have dilute urine. So ADH is going to help their kidneys absorb water, decrease that urine output. Because I am then increasing their fluid, what are they going to be at risk for? Overhydration. Okay, so one of the biggest side effects of this is something called water intoxication because they have the fluid, but they don't have the sodium to match it. So they got excess water, but they don't have enough sodium. And so they end up with something called water intoxication. And one of the biggest side effects of that is a headache. Okay, so that's going to be something that I am paying attention for over treatment with ADH. So it is their urine output when I'm administering this is going to decrease. Okay, that's the effect that I'm going for. So we talked about because they have too much fluid, they also are not going to have enough sodium. Okay, so if I'm looking at somebody's lab values, their sodium levels are going to be low. For vasopressin, that is actually what is given when somebody in emergencies, and it is a severe vasoconstrictor. Okay, it also can cause seizures. So it can be given orally, intranasally, sub-Q, sublingual, or IV. When I'm administering this, because it is dealing with fluid volume, monitoring, what's going to be important for me to monitor? Intake and output. If I said that the symptoms of this are they're either going to pee a lot or not enough, then obviously I want to know what that looks like, right? I need to know how much they're intaking and how much they're outputting. I think somebody else said it, blood pressure, right? So their fluid status, that is a direct reflection of the pressure of the fluid within their body, right? So I'm monitoring their blood pressure. Also, the specific gravity of their urine to tell me whether that is dilute, if it's low, or if it's high, if it is concentrated. Okay. And then creatinine clearance is my kidney function. So, in for vasopressin, because that one specifically causes vasoconstriction, then I would want to use that cautiously / not administer. In heart disease or people with impaired circulation. For just kidding. Okay, I can't go back. Let me pause. All right, so vasopressin, that's all the things that I just said. Complications, water intoxication, biggest indication of that is going to be a headache. It can cause an MI because I am vasoconstricting, okay? So if somebody already has impaired circulation, then giving them something that's constricting their blood vessels could put them at risk for an MI. Yes. That's this. Yes, it presses your vasos. It is constricting your vessels. Yep. Um, we've already said that. And just use caution in people who have renal impairment because that risk for water intoxication is increased. So this is just a little picture of diabetes insipidus. People you would be who are at risk for this are people who've had some sort of pituitary tumor or head injuries. Okay, so they are going to be at risk for dehydration, and that is why we are giving them the antidiuretic hormone. All right, moving on to adrenals. So what does our adrenal gland do? Okay. Cortisol, very good. Yes, fight or flight, we there. Steroids. So what we are going to be talking about is steroids, but you are correct. So malfunction of that is going to look like symptoms of if those are impaired, okay? Also sex characteristics, and y'all mentioned the stress response because of epinephrine, norepinephrine. So I'm looking for stable levels of that. I will monitor my hormone levels. It is, I guess I'll just talk about this on the next slide. All right. So, like I said, we're going to be talking about steroids. So, when Addison's disease is one of the biggest things that we will discuss, two of the complications from steroids are Addison's disease and Cushing syndrome. And I have little pictures here that tell you kind of what's going on with each of those. So, to treat Addison's disease, we will give them glucocorticoids and mineralocorticoids. Okay, so glucocorticoids, the prototype for this are hydrocortisone. I had somebody ask me, were glucocorticoids indicated for what are we talking about right now? Endocrine, endocrine, respiratory. What do these do? What do steroids do? Why do I give them usually? What'd you say? Anti-inflammatory, okay? But also because this is mimicking the that hormone or that steroid in my body, then I can give it if there is a impairment, right? If it's low, this can be given as a replacement. But most of the time when you're giving somebody glucocorticoids, it is used for inflammation. So that is why when you are filling out your drug card, I told y'all to fill them out based on I assigned them by unit, right? But you do need to understand that many medications can be given for many different things. And this goes back to what I said. You need to know what that reason is. I can't say that I'm giving somebody hydrocortisone because they have a swollen knee if I'm really giving it because they have Addison's disease. Does that make sense? You need to know why you're administering the medication, especially because if they don't have a deficiency, they're going to be at a greater risk for complications from that, right? So it can be administered for acute and chronic replacement for adrenocortical insufficiency, whether that be Addison's disease or more severely adrenal crisis. Um, can be used for non-endocrine, like I said. They give it for pain associated with cancer, increased inflammation, and when people have allergies, which we will talk about. Um, so adverse effects of this are going to be because I am giving them this adrenal replacement. My adrenal gland is going to say, okay, no worries, I don't need to make this anymore, right? So a risk of giving this is that my body stops doing what it needs to do, and then I am going to be deficient, okay? So you do want to use this cautiously, specifically, like I said, if you're giving this to somebody for inflammation versus they have a deficiency, okay? It does. That is one of the biggest side effects of this. It's a glucocorticoid. It increases my blood sugar. Okay. So who else would I want to be very cautious in giving this to? If I'm giving this to a diabetic, what am I probably going to have to do? Yes, they're probably going to need, you got this, Rhonda. I got I need increased insulin, probably, right? I for sure need more frequent blood sugar monitoring, okay? Because they already have an impairment. And then too much of this is Cushing syndrome, okay? This is cortisol. So that could be naturally, you have too much cortisol, or it could be drug induced from glucocorticoids. Does that make sense? Okay, and I have a picture of that coming up. Um, so this can be given orally with meals to decrease GI side effects. It is best to give this in the morning because in our bodies, cortisol is usually released in the mornings. Okay, so to make sure that our bodies are using it the way that it is intended, it's best to mimic that. It can cause fatigue, so you might need to split the dose, okay? Um, if it is given IV, usually that is for emergent situations. Um, while I am administering this, I am monitoring CBCs, their electrolytes, their blood sugar, and then their cortisol levels. So they should, if they are taking this medication because they have an insufficiency, they should keep a dose with them, okay? Because they might need to supplement that. A time when they might need to supplement that could be when they're under stress. If you're caring for somebody in the hospital, what are they going to be under? Stress. So this particularly applies to you. If they have an insufficiency, they might need an increased amount. Okay. And then it can cause decrease the antibody response to vaccinations. So if you are giving somebody a vaccine, if they're scheduled for a vaccine with a live virus, you should not give them a glucocorticoid. Okay. That would be contraindicated. Most of these medications, some other common medications are prednisone, dexamethasone. The clue there, most of the time, those are going to end in SONE. okay, for steroids. That's a good indicator that that is what you're administering, okay? They also, I think somebody said this, they also can suppress what? Do we know? My immune system. So what would I want to do? I'm monitoring for infection. That is 100% correct. If my patient is also already, let's say, I said I could give this to somebody who has cancer, if they're already taking medications that decrease their immune system, that is a time where you are doing a risk versus benefit. Some people are good with the risk, right? Some people are, I'm not leaving my house. I'm in so much pain. I need this medication. If they are having to interact with people and be at risk for, or they're frequently hospitalized, they're going to be at a very increased risk for infection. Okay. Um, so here is, if I were to give that in excess, if they have too much cortisol or I have given them too much glucocorticoid, they are at risk for Cushing syndrome. Okay. So this is what that is going to look like. One of the biggest indicators of these, high blood sugar, risk for infection, like I said, moon face. That is like, as soon as you look up a steroid, that's what it says. And it really is. I've watched people start steroids and the entire shape of their face changes to very, very circular round face. Okay. And then osteoporosis, if this is given, again, this is going to be more of a risk if they're getting it in excess or if you're giving this to people who don't have an insufficiency. Long-term use puts them at risk for osteoporosis. Okay. So again, that is a risk versus benefit. One of the biggest things with administering steroids, like I said, when you're giving it, your body says, okay, I'm done here. I don't need to give it anymore. You're doing it. So what would be important for me to not do? Yes. So I am going to not abruptly stop taking this, right? It's very important that you taper down. If y'all have ever been prescribed steroids when you were sick, they'll tell you take 2 this day, to do that for 2 days, take 1 this day, do that for 2 days, and then you stop, right? You taper that down to give your body a chance to pick up the slack. Okay? hmm I could see it. Gru is he's got that body. Um for okay, so now we're getting into mineralocorticoids. These are used in conjunction with corticosteroids to treat Addison's disease, or if people have hypoaldosteronism, and if they have congenital adrenal hyperplasia. Okay, so this is going to mimic the effects of aldosterone in our body. Our adverse effects, usually there aren't a whole lot associated with this, but because it is going to affect, okay. So I probably said all of these things. Yes, I said all that. Just a repeat of hydrocortisone. This really drives me. My stinking mouse isn't working. Their weight, their blood pressure, and electrolytes, especially if somebody is at risk for diabetes, they have prediabetes or they have diabetes. I'm monitoring their blood sugar, giving it with food to make sure I decrease their GI distress, and then, so sorry. Um, Make sure I'm giving it in the morning, so I'm mimicking that normal hormone release. Not stopping it abruptly, we're tapering that dose. And then telling my patient to report if they have signs of a peptic ulcer, if they report like black tarry stools, adrenal insufficiency, so if they say they have fever, muscle joint pain, weakness, fatigue. Um, If they have Addison's disease, they're going to be on this forever. So very important to teach them that they're not just taking this for a short time, and that if it is due to an insufficiency, that they carry an extra dose with them, and wear an alert bracelet should they need be in some emergency situation. A client for a total hip arthroplasty. The client takes hydrocortisone for Addison's disease. Which of the following actions is the nurse's priority? What do we think? We're giving more, right? They're stressed, and I'm going to give more. I love that your brain went to I'm assessing first, but we're going to pretend we already know, okay? And we are giving them more. So very good. Huh? Yes. A.
Big surgery saving.
Yes. Let's go back.